Cord prolapse. Cord prolapse is an obstetric emergency and it is one of the causes of fresh stillbirth associated with high perinatal mortality. Cord prolapse is defined as the descent of the umbilical cord into the lower uterine segment where it may lie adjacent to or below the presenting part. Types of cord prolapse: cord presentation, overt cord prolapse, occult cord prolapse. Cord presentation, umbilical cord is below the presenting part and it is felt lying in the bag of the membranes. Overt cord prolapse, the cord lies below the presenting part in the vagina or outside the vulva. Occult cord prolapse, the cord is placed by the side of the presenting part. Incidence of the cord prolapse is 0.1 to 6% and it is highest 20% in transverse lie. Causes of cord prolapse: it is mainly due to incomplete fitting of the presenting part into the maternal pelvis. It can be spontaneous or the main risk factors of cord prolapse is during ARM, artificial rupture of membrane, when the presenting part is high or if the presenting part is not fixed into the maternal pelvis, and during procedures like external cephalic version, internal podalic version, or during applying fetal scalp electrode, more commonly seen in multiparity and preterm labor, and in mothers with cephalopelvic disproportion, and in fetus having congenital anomaly, breech presentation, transverse lie, oblique lie, and in the second twin, and in placental conditions like low-lying placenta and polyhydramnios. Maternal complications is operative vaginal delivery. Fetal complications of cord prolapse is mainly due to cord compression and umbilical artery vasospasm, which may lead on to birth asphyxia that will lead to HIE and increasing the chances of perinatal mortality from 15 to 50%. Diagnosis of cord prolapse is by vaginal examination when the cord loops are felt below the presenting part at or outside the introitus. Ultrasound examination in case of intact membranes. In case of occult cord prolapse, when the loops of cord are present adjacent to the presenting part, it is difficult to diagnose and may present with FHR abnormalities during the process of labor. Management of cord prolapse: if the baby is term, it is by LSCS, and if the baby is preterm, we can opt for conservative management or by LSCS. If we opt for conservative management, we can hospitalize the patient and serial ultrasound monitoring with the hope that the loops of the cord may ascend into the upper segment. Prompt delivery is the only management to minimize hypoxia. That is, delivery should be within 30 minutes. Pulsation of the cord should be confirmed in between the contractions. If the baby is dead, labor is allowed to progress and vaginal delivery may be preferred. Steps to be followed to relieve cord compression: first, stop oxytocin, provide nasal oxygen and head low position. Maternal positions are exaggerated Sims, left lateral position with pillow under the hip, knee chest position, Trendelenburg head down tilt position, and we should filling up of the urinary bladder with the help of Foley's catheter up to 500 to 750 ml of saline and clamp the catheter, and manual elevation of presenting part. Other thing is tocolysis by the injection. Drug of choice is injection terbutaline 0.25 mg subcutaneous. Prevention of cord prolapse: avoid ARM if the presenting part is high or mobile. Women at high risk like polyhydramnios can be planned for elective admission at 37 to 38 weeks of pregnancy. ARM should be avoided if the cord is felt below the membranes. Perinatal mortality can be reduced to 5 to 10% if prompt delivery is conducted within 10 to 30 minutes. Thank you.